If you have ever been bit by a tick, or you've been diagnosed with Lyme or chronic Lyme or all the other co-infections such as Babesia, Ehrlichia, Bartonella, Rocky Mountain spotted fever, if you live in a tick endemic area, I highly recommend watching this interview. Hey guys, my name is Judy Cho and I'm board certified in holistic nutrition. And I have a private practice where we focus on root cause healing, and that often starts with a carnivore cures all meat elimination diet. So I did a thing not too long ago, and now I am a certified Lyme practitioner. I will always be a lifelong learner. And as you can tell throughout my channel, I've always been continuously learning and growing because in our practice, we get to see when things don't work fully. When I was looking into Lyme and Lyme disease, I wanted to interview someone that really is an expert in Lyme illness. And most people recommended Dr. Richard Horowitz. He is the founder of MSIDS. It is a questionnaire that we get into a lot more in this discussion, so I'm not going to talk about it too much right now. But he is also one of the experts in Lyme disease and chronic Lyme. He has worked with nearly 15,000 people with chronic Lyme, and so many of them are healing and in remission. We talk about all the different ways to support Lyme. What you do. Do we handle mold first? Do we handle an infection first? Do we handle gut function and an elimination diet first? We talk about a lot of these nuances. It gets very deep. He is such a brilliant man, and you can tell. So I highly recommend taking notes. And if you are suffering with Lyme, then I would highly suggest that whoever you are working with, that they look at Dr. Horowitz's MSID questionnaire and all the nuances and even his protocol that he recommends closer to the end. I love that he ends with hope. He knows that people can heal and he has seen it in his patients and he is super excited. You can totally see it in the way he shares and is excited about all his research and publications. And as we learn about more tick-borne infections, I hope we are ahead of the curve and know what to do when we get a bite and then can get support so that we do not end up having chronic Lyme. Let's get right into the interview. Hi, Dr. Richard Horowitz. I am super excited to have you on. I just recently got Lyme certified. Everyone recommended your book or many books, and then the MSIDS questionnaire. I have so many questions to ask you, and I'm super excited. I am a SIRS practitioner, and we started finding that certain people weren't fully getting better. And then Lyme is something that has been showing up more and more. So I'm so curious, and I'm so excited for the community to get to know you more. But if you can introduce yourself.
Sure. My name is Dr. Richard Horowitz. I'm a board-certified internist. At this point, I've seen over 13,000 chronically ill Lyme patients during the last 40 years. This year is actually my 40th year in clinical practice, and I will tell you it goes very quickly. And I have, some very ill patients who've come from all over the world to see me. And over the last 40 years, I've developed a model to treat Lyme and multiple tick-borne disorders that we'll discuss today. And I guess we'll discuss also nutritional components, right, of how to get some of these patients better, because diet obviously plays a huge role, right, in keeping down the inflammatory response in these patients. So thank you for giving me the opportunity to have a discussion with you.
What is Lyme? I know there's co-infections. If you could just tell us about tick-borne illness, where it's from, what's going on.
Sure. So Lyme disease itself, it's a bacterial infection from a spirochetal bacteria called Borrelia burgdorferi. There's a lot of different Borrelia that are out there. I sometimes refer to them as like cousins of Borrelia. It's not necessarily the original Borrelia that was discovered 40 or 50 years ago. There's been an evolution of these different Borrelia species over time. But essentially what Lyme does to the body is it creates chronic fatigue. People feel a lot of aches and pains all over their body. One of the hallmarks of Lyme is migratory pain, whether it's migratory muscle pain, migratory joint pain, where people have pain in their shoulder one day and then their knees 2 days later and their feet 3 days later, it moves around the body, or migratory nerve pain, which is actually one of the hallmark symptoms where people get the sensation of tingling, burning, stabbing, numbness feelings on different parts of their body that moves around. They also get memory concentration problems, problems falling asleep, waking up a lot in the middle of the night, mood disorders, depression, anxiety. It can even include OCD and psychosis, depending on whether you have co-infections like Bartonella. So we see this broad range of symptoms: chest pain, palpitation, shortness of breath. It's been called the great imitator, like syphilis was years ago. But, we have to be careful when we use the word chronic Lyme, because most of the patients who come to see me, they don't just have chronic Lyme disease. They do have a chronic persistent infection with Borrelia burgdorferi, but most of these people have Babesia, which is a parasite that looks like a malaria type organism, and causes day sweats, night sweats, chills, flushing, difficulty breathing with air hunger, shortness of breath, and unexplained cough. And they have Bartonella, which is cat scratch fever, or the initial one was. And that makes the neuropsych issues much worse, where they may have very excruciating pain in the bottom of their feet, very bad neuropathy. Their psych symptoms are much worse. They even get immune deficiency and low blood pressure. POTS dysautonomia can be very severe in this group. So it's kind of a multitude of infections that are getting into my patients. And the book that you had just shown, How Can I Get Better? What it does, it outlines a 16-point map of how you get better, meaning there are 6 different inflammatory triggers, things that cause inflammation in the body: Lyme, infections, Babesia, Bartonella. We're seeing a lot of environmental toxins, mold, heavy metals, sleep disorders, microbiome issues with the gut, or leaky gut with mast cell activation. People also have vitamin mineral deficiency. So all of these things contribute to inflammation, and inflammation is ultimately what causes fatigue and headaches and joint pain and memory issues. But then this inflammation has 10 downstream effects. It affects the mitochondria in your body, the cells that make energy. It affects the autonomic nervous system, the part of your nervous system that controls your blood pressure, your heart, your bowels, your bladder. And people can get autoimmune reactions, hormone disruption, low adrenal function, low testosterone. So when you look at my books, Why Can I Get Better? And the last one, How Can I Get Better? And even the articles I've published, you'll notice that when we talk about chronic Lyme, I really, in a sense, describe it as Lyme MSIDS, because it's like a person going into a doctor's office with 16 nails in their foot. And if the doctor only finds one nail and pulls it and says, come back in a month and tell me how you're feeling, they're obviously still going to be ill because the doctor didn't find all the other nails. So, my key message for people listening is, if you have Lyme disease, or in fact, if you have any chronic fatiguing, painful neuropsychiatric illness, the MSIDS map is very useful. Because whether people have been diagnosed with chronic fatigue syndrome, ME, myalgic encephalomyelitis, or fibromyalgia, or long COVID, or even dementia, the fact is that these are describing symptoms. They're not describing why people have the symptoms. And we find that even people who have chronic fatigue due to a virus, they can still get Borrelia burgdorferi, they can still get mold toxicity, they can still have POTS dysautonomia. So the model really applies to a broad range of diseases. And we think it's probably going to be accounting for a large part of the chronic illnesses that we're now seeing in the world.
Yeah, I think that makes so much sense. I have so many more questions from what you just asked, what you just shared. So thank you for all of that really good information. When you get a tick bite, and let's say you are positive for Lyme, how often is there a co-infection? So the Babesia, Bartonella. And do you ever see a co-infection without the Lyme infection?
It's a great question. You can see co-infections. Well, they wouldn't be co-infections. It would be an infection. Like someone can get a tick bite and get anaplasma or Ehrlichia or Rocky Mountain spotted fever, Q fever. Absolutely. They can get Lyme disease without other infections. In my practice, having seen 13,000 chronically ill patients, it's never just Lyme alone. These patients always have overlapping co-infections. So usually there's 4 types of infections. There's other bacteria. There's viruses. We do see a lot of viral reactivation, Epstein-Barr virus, herpes virus 6, especially in the people who've had COVID. COVID-19 causes a lot of viral reactivation in these people. But we do see the parasite Babesia show up in 80 to 90% of the cases who come to see me. And we even see Candida fungus. So a lot of the people have mold toxins, or they have a Candida fungal overgrowth in their gut. So all these different types of infections usually are found in my patients. But to be clear, yes, you can get just a tick bite and just get Lyme, or get Ehrlichia, anaplasma, relapsing fever, Borrelia miyamotoi. You can get these separately, but I think a lot of people get quite a few tick bites over time. So, one tick can transmit several infections at once, but I think probably what happens to most people is they do get multiple bites, and they're probably accumulating these infections over time.
That makes sense. We've also seen recently a lot of our doctors or the people we partner with, and then we started testing on our own. Epstein-Barr reactivated or mycoplasma also as well, and then all of these other viral. You mentioned the MSID, so maybe for the people that are unfamiliar, like is that a test? Is that a questionnaire? If you can explain a little bit about what that is, where people can even see it, and then beyond that, where do we even get started? So, if we work with so many complex cases and we'll see, okay, there's EBV is activated, mycoplasma. We see some bands in the Lyme, and then maybe they have SIRS or mold illness. So where should we get started?
Yeah, so it's a complex question because we're really getting to the heart of the matter. So first of all, MSIDS stands for multiple systemic infectious disease syndrome, and this is a model. All the factors on the model were published in the medical literature. The only thing that I did is one by one, year after year, when I started seeing these patients maybe 30, 35 years ago. At first it was Lyme, and then I discovered, oh, my patients have Babesia, this parasite, because they were getting these malarial symptoms. And then a couple of years later, we discovered Bartonella. So essentially what MSIDS describes is it describes 6 overlapping causes of inflammation and 10 downstream effects of that inflammation. So it's a map for healing. It's a map for you to get better. It doesn't mean that every person who comes to see us has all 16 points on the MSIDS model, but I will tell you, the majority of people probably have at least half of them. They probably have at least 8 out of the 16 in most people. And the most common ones are Lyme, Babesia, Bartonella. Mold toxins are showing up in 80 to 90% of our patients, as are heavy metals. Vitamin mineral deficiencies, very, very frequent. Microbiome issues, very frequent with mast cell activation, either from the Lyme or from mold toxicity. People who can't sleep. So the inflammatory factors, they're very common in most people. And from the perspective of downstream effects of inflammation, almost 100% of our patients have some adrenal dysfunction. The adrenals are like the battery of your body. So if your adrenals aren't working properly, you're going to have a tough time getting better no matter what your doctor is going to do. And probably 40 to 50% of our patients have POTS dysautonomia with low blood pressure. Whether they got it from COVID-19 or whether they got it from Lyme or even mold, they still get it, and it's quite frequent. And it's important to check for it simply because the symptoms of autonomic nervous system POTS is fatigue, dizziness standing, feeling like you're going to pass out or you do pass out, memory, concentration problems, anxiety, palpitations. These symptoms overlap Lyme and Babesia and Bartonella, but those are treated with antibiotics or antimalarials. POTS is just treated by addressing the vagal dysfunction, the vagus nerve dysfunction in the body. So the MSIDS model for me is crucial. It's a key to getting people better no matter what the name of the chronic disease is, whether you call it chronic Lyme or you call it Bartonella or you call it, I'm just finding that all these overlapping factors are present in the vast majority of these chronically ill people. And, it's because we're living in a world with everyone's exposed to these infections. They're exposed to these toxins. The foods we're eating, right? We know the soil's been depleted. Most people do not get the vitamins and minerals they need, especially in the standard American diet or SAD diet, right? As has been discussed. In fact, they just had an article come out. I'm sure you just saw it on these highly processed foods leading to higher death rates right now in people. That you can't just eat these processed foods, right? They're really bad for you. So the MSIDS model really, it's just a map for people to get better. So where do you start? So on my website, www.cangetbetter.com. If you go on the website, there's a section that'll say symptoms or questionnaire. And we developed a validated Lyme symptom questionnaire. We published it in 2017 with researchers from the State University of New Paltz. This was published in the International Journal of General Medicine. This questionnaire was validated in 1,600 patients in 3 medical practices. So it's validated. So if you're not sure you have Lyme, without even taking a blood test, you can download this questionnaire from my website, cangetbetter.com, score it. And if you score over 63, there's a very high likelihood you suffer from Lyme disease and possibly co-infections. If you score between like 45 and 62, there's a moderate chance. If you score between 25 and 43, there's a mild chance. And if you score below 25, it's unlikely you're really going to have Lyme disease. But it's a good starting point because the 38 symptoms that are there are the most common symptoms you get with Lyme. So if you fill this out and you see that you have 30 out of 38 symptoms, And you notice that the joint pain, and the questionnaire asks you, does it migrate? Do you have migratory joint pain or muscle pain or nerve pain? Tingling, numbness, burning, stabbing. Those are hallmark symptoms of Lyme. There's only 7 diseases in medicine that cause migratory pain. And I used to joke with doctors that unless you graduated at the bottom of your medical school class, you should be able to tell the difference between inflammatory bowel disease and lupus and gonococcal arthritis and acute rheumatic fever and Reiter syndrome, right? I mean, these are very distinct diseases from chronic Lyme, hepatitis. Those are the other 6. So once you see migratory pain and you see this multisystemic illness, where people have good and bad days, where the symptoms come and go, and the symptoms, migrate around your body, it's really going to be a high likelihood you suffer from Lyme. And then you do a blood test. And I don't usually do standard blood tests through LabCorp or Quest because a Western blot only checks for one strain of Borrelia. And as I said, there are multiple strains or cousins of Lyme. We like the IGeneX immunoblot, IgM, IgG, that checks for 8 different strains. So there's a game I play with my patients called Lyme Bingo. And if you have any one of these 5 numbers that shows up on your immunoblot, bingo, you have been exposed to a Borrelia species. Could be Borrelia burgdorferi sensu stricto, the original one that caused Lyme, or it could be a European strain or another one. But the numbers to look for on an immunoblot are 23, which is the outer surface protein C of the bacteria, 31, which is the outer surface protein A, 34, which is the outer surface protein B, 39, and the 83/93. Any one of those bands in the right clinical setting gives a doctor a good clinical sense that, yes, you've been exposed to a Borrelia species. We need to do a further deep dive and find out what else you may have wrong with you.
If you are really positive on MSIDS, do you even need to do because most IGeneX testing is not covered by insurance. And then if you go to standard care, it's usually you have to I think it's like 2 different tests. Like one is the Western blot you have to fail. And then also there's one other. And then they're like, okay, maybe you need further testing to be even positive. So if your MSIDS already shows that you're highly likely, you have the 30 out of the 36, do you even need to do the IGeneX testing?
Well, you do. But here's the thing. IGeneX, first of all, is covered for all patients who have Medicare. So for Medicare patients, there's not going to be any major costs out of pocket. IGeneX these days is also submitting to insurance, and I just saw that people are getting back like 70% of whatever they're paying. But here's the thing. You can do local labs, and the test you're referring to is the 2-tiered test of an ELISA followed by a Western blot. The problem with it is that it has about the sensitivity of a coin flip, roughly 50-50 chance you're going to get back a positive. So 50-50 is not really great odds, right? If you're negative, it doesn't mean you really can rule it out. So you can still do a Western blot from Quest or LabCorp and ask them to report the bands. And it's possible you will get highly specific Borrelia bands. But on a Western blot, the 31 band that I was describing before as being specific, it's not as specific on a Western blot because you can get false positives from Epstein-Barr, autoimmune diseases. So it's not as specific. But you can still use local labs to start. But if you only did an IgM and an IgG immunoblot from IGeneX, it's somewhere over $300 to do it, and your insurance is going to give you back a certain amount of that funding. If you're a chronically ill patient, it's worth spending that money because it's not a huge outlay, especially if your local labs are negative. But what I should tell you about the testing with people who, the doctors who say, well, you need 2-tiered to be positive to have Lyme, it's not true. That idea really came from health departments to screen patients epidemiologically from a perspective of like determining whether the global population or the population in the US has Lyme or not. It's really for epidemiological purposes, not to make an individual diagnosis. So I never use an ELISA followed by a Western blot to make the diagnosis. I really hardly even do the ELISA. It's a waste of time, truthfully. So if people have positives, great. But I've seen the C6 ELISA, which is an ELISA that looks for 3 strains of Borrelia avzelii, which it's a European strain that causes a rash called ACA, Borrelia guarini, which causes neuroborreliosis, and Borrelia sensu stricto. Those 3 are in a ELISA C6, but I've had people with a positive ELISA C6 and have an ELISA, or a positive ELISA, a negative C6, or a positive IFA, immunofluorescent antibody, and the ELISA is negative. the tests are all over the place. So I advise doctors and patients, if you're not getting back a strong test, that's really the beauty of an IGeneX immunoblot. You're going to stand a better chance of finding Borrelia-specific bands. But if you use a panel approach, ELISA, C6 ELISA, immunofluorescent antibody, there are lymphocyte transformation tests, there's direct testing by PCR culture, nanotrap testing looking for the 31 OspA in the urine. There's a whole range of testing. So if one test is negative, there's other panels of tests that the doctors can do, but you really want to get back a positive test, not just because you have a strong clinical suspicion, but for medical legal reasons. It's best to be able to prove that you have it for doctors who are treating.
We have found that some people will take the IGeneX test, and more so they'll be positive there than, like we were talking about, the Western blot through LabCorp Quest. But we have seen more efficacy where maybe if we do like an herbal challenge before the test, they will show a more immune response than if, say, that they didn't take cat's claw, for example.
It's a good question. I don't think there's been a good published study on it. The only study I know of where they looked at how to increase the sensitivity was published in the journal Medical Hypothesis a few years ago by a friend of mine, Dr. Christian Perrin, who's an infectious disease doc in France. They talked about using, for example, biofilm agents, because we know now that Lyme and Bartonella are biofilm, quote unquote, persister bacteria. This means that these bacteria are hiding under biofilms. Biofilms are, for example, you go to your dentist to get the plaque taken off your teeth, or you get gingivitis. And you can't get to the bacteria if you don't open up the biofilm, get rid of the plaque. It's the same thing with Lyme and Bart. They're hiding under biofilms. There was a hypothesis that if you take biofilm agents, cinnamon, clove, oregano oil, essential oils, biocidin, peppermint oil, there's a form of stevia from Nutrimetics that we use as a biofilm agent, that you might be able to increase the sensitivity of the test. They were also talking about it for DNA analysis by PCR. But I don't think there's enough good published research on it. So it's possible, anecdotally, you are seeing that. I think we need some good clinical studies to prove it, but it's very possible that it's true, that it may work by kind of bringing the organism out of hiding. Definitely possible.
So we work with a lot of people with mold illness. So people have been diagnosed with all the different things that you said are more symptoms. And then they're not getting better with all the medications they're using. So they get desperate enough, try a carnivore diet, and they find a lot of healing with, I think it's that the nutrients are more bioavailable. They're putting less ultra processed foods in their system, so there's less inflammation. But then they get stuck. And then as they hear some of my content or some of the things that I share about environmental illness, then they test for SIRS or mold illness, and they find that their home has mold and that some of their markers of inflammation are also present too on the non-adaptive side. Then we go through a protocol of taking binders and trying to reduce the mold exposure. And for many people, they'll get better, but then some people get stuck and we find that they also have Lyme. Some of the arguments we hear is that if you reduce the noise of mold, then there will be overall less inflammation, and then your immune system can then target the Lyme and other viral infections. It can then support the body to remove those things. Do you go after Lyme first and rather than mold? And what is your logic behind, or what have you seen with your tens of thousands of patients?
So, it's a very good question, and it has to be individualized, because there are some people that before you start treatment, like if someone has a bad case of leaky gut and they have mast cell disorder and they've got inflammation in their gut and their detoxification pathways aren't working, they're overloaded with mold or toxins. And let's say you start treating them, you try to treat them, and you notice that they're herxing, they feel terrible. This recently happened to a patient of mine. We just stopped, and I detoxed her for a couple of months and then went back to the Lyme treatment. But it really is individualized. The only reason I try and start with the Lyme and the Bartonella treatments early on. Mold treatment can take 6 months or a year.
Yes.
So when I look at someone for initial history and physical, I go through all 16 factors on the MSIDS model. So first thing I want to do is identify what are the factors causing inflammation, right? The 6 factors we talked about on the MSIDS model, and what are the 10 downstream effects on the MSIDS model. If your adrenals are phase 3 and they're very low, I'm going to make sure I treat that early on, because otherwise you're trying to treat mold or Lyme, right, with your battery being low. Right. If you have severe POTS, I'm going to start them on a vagal retraining program. I may give them midodrine, salt, fluids, licorice to bring up their blood pressure, right? So I'm going to address a lot of these MSIDS variables at the same time. I don't do like one thing after another. I'm usually, the example I use is kind of like if you have ninjas attacking your castle, You're not going to just go after one ninja. You have to have like an army, right? That's going to basically take out as many of these ninjas as possible before they get in. So if you have mold, overlapping low adrenals, overlapping POTS, overlapping I'm not sleeping, overlapping I have microbiome issues with mast cell activation, I try and do it all at the same time. Now, here's the way it usually plays out. Most of my patients get tremendous detox support while they're doing dapsone combination therapy, which is the primary protocol I'm now using. Because it's an 8 to 9 week oral generic protocol, I hardly ever have to use any IV drugs any longer. I don't do long-term antibiotics any longer, ever since I discovered dapsone. But it's only an 8 or 9 week protocol. So let's say I do that. I know that mold is going to interfere with the success. I know that Bartonella is going to interfere with the success. But once I've gotten them through the 9 week protocol, then roughly 6 to 8 weeks later, when the counts have come back from dapsone, because it causes an anemia where I have to use a lot of folic acid, I can then do these 2-week antibiotic pulses. But when I'm not on antibiotics now, after doing the 9-week protocol, I'm detoxing the mold and I'm working on the microbiome, right? But it doesn't mean I won't get their microbiome in shape before I start giving them antibiotics, right? I might start giving them 4 different probiotics with over 500 billion of like 16 different, bacteria, all shown to be beneficial with, all types of bacillus and lactobacillus, and, bifidobacterium, et cetera, to get them stable with Saccharomyces boulardii to protect from C. diff diarrhea. I am getting their detox pathways ready for the protocol for the herxes that are going to happen. But because it's a short-term protocol, once I'm done with those antibiotics and I've knocked down the load of the bacteria, even if I've not knocked it out, I then have a chance to go after the POTS and the mold and everything else. But the patients are not going to stay as sick, because if all I did was go after mold, which can easily take 6 months to a year, depending on how much mold you have in your body, right? Then I've lost a year of people still being sick from Lyme and tick-borne, where I could have knocked the load of the bacteria down with the first 8 or 9 weeks of dapsone, right? So that's kind of the logic. But clearly there are people, I can't do the dapsone initially, and I have to reverse the order and work on some of the other factors, because like if you don't deal with these other inflammatory factors, like some people just don't sleep at all. Well, it doesn't matter what you do for people. If they don't sleep, you're never going to get them better. The inflammatory process doesn't shut off. So I'm really working on multiple levels. It's kind of like, 4D chess at once. But the 16-point MSIDS model is the map for what I'm working on. Oh, I'm working on the adrenals, and I'm working on the detox and the mold and the microbiome and the POTS. But I'm not doing one or the other. I'm doing as many as I can. Now, microbiome, I'm doing the whole time. Right. POTS, I'm doing pretty much the whole time, right? People are sending me sitting and standing blood pressure readings and pulse rates so I can adjust midodrine and salt, et cetera, along the way. So it's not an either or situation. But it is individualized, because there are some people who are so toxic and whose microbiomes are, so affected, whose pathways cannot detox. They have to first open up their detox and get rid of a certain amount of the toxins and work on the mold and work on the microbiome and work on the POTS before you ever touch antibiotics. But still, in my practice, 95% of the time, I'm able to usually get in 1 round of dapsone. And then even if I have to wait a few months to do a pulse, I'm spending my time then working on all the other MSIDS variables. And I find it's quite efficient, because by the time I'm done with 12 months in a year, most of these patients are significantly better by the end of a year.
Yeah, I kind of see a lot of what you just explained in our practice. So we have seen people where now they hear about SIRS or mold illness, and they will say, I want to bypass all of the diet, gut function, and the drainage and detox pathways. And I just want to go straight because I know for sure I have it. So we have tried just to accelerate their healing and put them there. But then we find, oh, you can't even tolerate the binder. You can't even tolerate a little bit. And now you're crashing, or you're having really bad herxing symptoms, or even mental illness symptoms. So then we have to go back and, okay, we need to start really slow. Let's start with drainage, or let's start with the microbiome. So I totally understand that. And I absolutely agree. It's very individualized. You've brought up dapsone. Can you explain, what is that protocol? You said it's only 9 weeks. So if you can explain a little bit about that.
Sure. So one of the biggest scientific findings, I believe, in the field of Lyme and tick-borne in the last decade was about 8 or 9 years ago. There were several university-based researchers. It was like Ying Zhang at Johns Hopkins University, Stanford University, University of New Haven with Eva Shapi, Kim Lewis at Northeastern. They started talking about persisters and biofilms. And what this meant is up until about a decade ago, we thought Lyme disease only had a cell wall form, meaning the bacteria was actively growing, and that's where penicillins or cephalosporins would generally work. Tetracyclines work on them too. They had an intracellular form. They would go inside the cells. That's where, again, where tetracyclines, macrolides like Zithromax, Biaxin would work. And then they had what we thought of was a cystic form, also known as a cell wall deficient form, S form, L form, round body. So those were the three main forms. And when we were treating Lyme, let's say a decade ago, we would have given a cell wall drug like Omnicef or Ceftin with plaquenil and grapefruit seed extract for the cystic forms. And then let's say Zithromax for the intracellular form with nystatin to keep down yeast, bunch of probiotics. But what we didn't know is that there were other forms of the bacteria which allowed it to persist. And these are the biofilm persister forms. So what does that mean? It means that when you give, in some of these bacteria, not every bacteria is a biofilm persister bacteria, but Lyme and Bartonella are, it means that there are certain forms of the bacteria that go to sleep. They go dormant, and they're hiding under biofilms. So your immune system won't recognize it necessarily under the biofilms. If the biofilms are not opened, your herbs or your antibiotics are not going to penetrate well to get in there to help the patients. So the biggest finding we've found in the last 10 years is by using multiple biofilm agents to open the biofilms. So the herbs and the antibiotics can get where they need to go. And then using persister drugs. What are persister drugs? Well, other persister bacteria are Mycobacterium tuberculosis, Mycobacterium leprae. So TB and leprosy, for example, are persister bacteria. So what I did when I discovered 9 years ago, that Lyme was a persister bacteria, I immediately went to the Mycobacterium literature and said, gee, if they're curing leprosy with rifampin and dapsone for 1 year, which is the regimen for curing a persister bacteria, I wonder what would happen if I added a tetracycline like doxy to rifampin and dapsone, right? It was logical.
Right.
And what happened is it worked, right? So I didn't have to have billions of dollars from funding to figure it out. I just said, oh, hold on. It's a persister bacteria like Mycobacterium. Let's look at the drugs. And when I looked at dapsone, dapsone is used to treat leprosy. The beauty of dapsone is it's an oral drug that's generic. It has incredible penetration into the central nervous system, as good as any IV drug you will ever use. It is anti-inflammatory. It hits myeloperoxidase, a certain enzyme in the body that causes inflammation. It has anti-malarial effects, helpful for babesia. It hits autoimmune disease. There are people with Beset syndrome and autoimmune illness that use. So this drug is kind of a wonderful drug because it hits persister bacteria. It gets up into the central nervous system. It's anti-malarial. It's anti-inflammatory. It hits autoimmunity and everything that a drug should have for treating Lyme. I borrowed it from the Mycobacterium literature and started doing studies. And my first study was in 2016, using dapsone as a novel drug for the treatment of chronic Lyme. And lo and behold, we found it worked even in low doses of 25 to 100 milligrams. So over the years, and I just published my 9th article, by the way, it's live today.
Oh, congratulations.
My 9th dapsone article is in the journal Microorganisms. If you go online and you look up microorganisms, Horowitz, 2024, dapsone, you'll find the article. The article is combining double-dose dapsone combination therapy with high-dose dapsone combination therapy for the treatment of chronic Lyme disease and associated co-infections like Bartonella with a literature review. So these are 3 case studies we published. 3 ill women who are ill for very long periods of time who are now in remission from doing these short courses of oral dapsone combination therapy with pulsing. So the article will explain how I did it, but basically, if you want to see the entire protocol, it was published in Microorganisms, September 2023. So any doctor and patient that wants to understand the protocol and how I do it exactly, you just go to the article, the 8th dapsone article, Microorganisms, September 2023, Horowitz et al. You will find the entire protocol, every supplement, every drug, every blood test that I do, when I do EKGs, when I check methemoglobin levels, every detail to the protocol is in that article. so that in the middle of a worldwide epidemic, any doctor can take that article and use it to help their patients. But ultimately, the beauty of this protocol is that what's been shown with these persister bacteria is that if you leave an antibiotic on board the entire time and never pulse it, you will lower the load of the bacteria, but you'll never get rid of it. When you take the same antibiotic, an example they use is oxacillin. It's an antibiotic used for Staph aureus. They've shown in culture, if you give oxacillin 24 hours a day for weeks, it'll lower down the load of the bacteria, but it'll never completely eliminate it. Whereas if you take the same drug and you pulse it, and you give it for a couple of weeks and stop it, and then you wait for the persisters to come back and grow, and then you hit it again with a pulse, and you lower the load of the bacteria, and then you stop it, and you let that load of persisters come back, and you keep pulsing the antibiotics, it more efficiently gets rid of the persisters. The persisters are the main reasons why Lyme patients have chronic inflammation with this disease. It's these persister forms that are really driving the inflammatory response. So once we hit the persisters and lower the load, doing it with opening up the biofilms, we're seeing miraculous results in our Lyme community, better than any regimen I have tried in the last 35 years. And I'm trying to hire a researcher because the Department of Defense has a grant out. I need to get it in within the next 6 to 7 weeks to do a multi-center, placebo-controlled, randomized trial on dapsone combination therapy to prove to the world once and for all what I know to be true. Because once we have a randomized placebo-controlled trial, everyone will believe it. But until we do it, the politics of Lyme disease are going to persist, which is why my next step in medicine is to get this randomized trial done. And that should really benefit the Lyme community at large.
In terms of the pulsing, so in the article, do you explain like how to pulse and how often, and then the supplements or other medications you would take afterward?
On an average, I would say the pulses are roughly every 2 to 3 months.
2 to 3 months. Okay.
So once you've done the 9-week protocol with dapsone, usually it's with doxyaminocycline, rifampin, sometimes pyrazinamide if Bartonella's there, with zithromax, with methylene blue, and all of these. It's in the article. After they've done with the first 9 weeks, when they've significantly lowered the load, dapsone causes anemia from a folic acid inhibition. Okay. So we have to give very high doses of L-methylfolate and leucovorin to help stop and reverse the dapsone-induced anemia. So people can drop 4 grams of hemoglobin, even 6, but it will reverse within 2 months. But the reason we wait 2 months to do the next pulse is I want the labs to come back to normal. I want the anemia to reverse. The methemoglobin levels are actually very well controlled now because we're using higher doses of methylene blue, 300 twice a day, with antioxidants like glutathione, vitamin C, vitamin E, NADH, and even cimetidine, old drug for the stomach, lowers methemoglobin. So the methemoglobin, where you don't carry oxygen well, is no longer a big issue with dapsone. It's really the anemia, and Herx's are you expect. If you don't get a Herx, it would actually be unusual. And you have to be G6PD positive. There has to be an enzyme. You can't be glucose 6-phosphate dehydrogenase deficient, or you will get more of an anemia. But the pulses are roughly every 2 to 3 months. So in between, when we're not doing antibiotics with pulsing, we're detoxing the mold. We're dressing the pots. We're treating the hormone dysfunction. We're treating the microbiome. I'm working on all the other MSIDS factors that are off, overlapping causes of inflammation and downstream effects. And we usually will do a 1-month mitochondrial regeneration when they're done with dapsone, just because you get a lot of free radical oxidative stress when you're using these drugs or just killing off the bacteria. I mean, we get free radical oxidative stress living on the planet from all these toxins and even drugs people take. But I'd say probably a third, 40% of the people notice after mitochondrial regeneration, transfer factors, ATP 360, CoQ10, MitoNR with nicotinamide riboside, Inata NADH, MitoPrime from Zymogen. There's a whole protocol we use. People tell us that their energy levels pick up in a certain amount after they do this protocol. So we've got this like tweaked now. So it's really just kind of plug and play, like figure out the 16 points on the MSIDS model. It's making you sick. Try and go after the bacteria. Make sure you keep going back and forth to address all the MSIDS abnormalities. It's not rocket science. It's just being a little obsessive compulsive to make sure you're not missing anything on the MSIDS model.
Right. So it's making sure that you're not missing another nail, which I love. I love this MSIDS questionnaire. So it sounds like this is more for chronic Lyme. What if I know I have a tick bite, I send it in and it's positive? in that case, do you just do like the few weeks of antibiotics? How do you treat that?
Yeah, so it's a bit different. So if you had a tick bite with no symptoms, so the problem with it is that you should save the tick and put it in a little plastic baggie with a blade of grass or an alcohol swab and send it off and see what's in the tick, because you really want to know what the odds are of what diseases you can get from that tick. So health departments in most states will do it. Technology in Colorado has a good place to do it. I think Mather's lab in Rhode Island has a good lab. There's a bunch of them where you can send the tick. But the point is, the general knowledge base out there is that, oh, the tick needs to be on for 24 to 36 hours to transmit Lyme. It's not really true.
Right.
They've shown that if ticks partially feed on another animal before they get to you, then the spirochetes that are in their midgut travel up to the salivary glands and they're ready to be injected into your skin the minute they bite you. So I have patients who have told me the ticks are on them for hours and they've gotten sick. So usually, 10 or 14 days of tetracyclines like doxycycline is usually enough if you have a tick bite and it's been on for a bit, difficult to remove, right? If you have a bullseye rash, that's a different story. Okay. You've got to be on an antibiotic for generally, and the IDSA would say it's less, but we still generally would treat for at least 28 days. And what I would do a little differently these days, I would use biofilm agents because, and you'll see in the article we just published in Microorganisms just this month, that they're now finding biofilms in the tick midguts also. And this could explain why some people actually go on to chronic Lyme, that the biofilms may be there from the beginning and they're protecting the bacteria. We certainly need a randomized trial on that. That's an important one that someone should do a study at some point. But it's very different whether you have symptoms or not, because, for example, let's say you get a tick bite and within 4 or 5 days, you start getting a fever and a headaches and aches and pains. Well, you don't wait for a titer to come back for Ehrlichia, Anaplasma, Rocky Mountain spotted fever. You just put people on doxycycline because people can die if they don't get it in within 7 days and you've been exposed to Rickettsia rickettsii, which is Rocky Mountain spotted fever. Even in children less than 8 years old, pediatricians used to worry about giving tetracyclines because the older tetracyclines cause teeth staining, but doxycycline does not. You can even give a pregnant woman a short course of doxycycline. It will not cause teeth staining. This is directly from the CDC, by the way. When I worked at HHS on the first round of their tick-borne disease working group, I got this directly from members of the CDC who were working with me. So the whole point is, what tick bit you? Was it Ixodes scapularis? Was it a Lone Star tick? Because the Lone Star tick contains something, the mnemonic that I like is TEARS V. TEARS V stands for tularemia, Ehrlichia, alpha-gal, rickettsia, stari, and viruses like the Heartland and Bourbon virus. So you also need to know what type of tick. Was it a wood tick or a dog tick that gives you rickettsia or tularemia? So you need to know what type of tick it was, how long it was on for. Are you developing symptoms? An easy test if you're developing symptoms early on, get a CBC and a CMP, because if you have low white cell counts, leukopenia, low platelet counts, thrombocytopenia, and or elevated liver functions, transaminitis, any one of those three means you could have Lyme, Borrelia burgdorferi, Borrelia miyamotoi, Ehrlichia, Anaplasma, Rickettsia, Q fever. The viruses, Heartland and Bourbon, will also cause that, but they're not responsive to tetracycline. But the point is, those markers tell you you need to be on a tetracycline ASAP. You do not wait for the antibodies to come back. Now, if you do get a bullseye rash and you have tingling or numbness in your extremities or your face, the Lyme has already disseminated. It's gone into your peripheral nervous system. If you've got tingling, numbness, burning in your arms or in your face, you've already have disseminated Lyme. 28 days of antibiotics is not going to cure that, right? So you also have to look, even if you had an EM rash, is it fatigue, right? That's okay. But what about headaches? It got into the CNS. If you have Bell's palsy, it got into the central nervous system. If you have memory concentration problems, it got into so the length of treatment and how you treat it also depends on whether it is disseminated. And if you have multiple EM rashes, then it's absolutely disseminated throughout the body. So the length of time then is going to change. And that's where I would start to think about using these persister drugs earlier on. Now, fortunately for me, well, fortunately or not, I don't really see much early Lyme anymore. It's only the chronic patients who failed 40 doctors, 50 doctors who come to see me.
Okay.
But if you're a patient with early Lyme, you do need to differentiate whether it's disseminated early on, right? Biofilms or not. I mean, these are kind of important questions, and they've not all been solved, by the way, in the medical literature. These are questions that still we need research, but these are the basic questions we need to answer.
Yeah, I think it's so important to understand this because I worked with a manager when I was in my business days, and her parents passed away from Rocky Mountain spotted fever. And that was the first time I ever heard of it. But she didn't have parents because of that. And they were gone when she was very young. So they were probably very young as well. So it's super serious. And it's something to consider when we are sometimes worried about overusing antibiotics. But I think in these cases, it's a life or death situation.
Yeah, I don't think 10 days or 14 days of doxycycline, if you support the microbiome of the gut. And again, I'm using 3 or 4 probiotics at the same point.
Okay.
Theralac, orthobiotic, Zymogen has a probiomax 350 billion with these 16 different strains that are acid resistant. They get into the lower gut, right? Saccharomyces boulardii helps stop antibiotic diarrhea. If you're using microbiome support during and after the treatment, risk benefit from my perspective, it is absolutely worth taking it. Where I think it's going to get tricky is the Haemophilus longicornis, the Asian bush tick, that is now spreading across the US very rapidly because it's a hermaphrodite. It doesn't need a blood meal to feed. They're now showing a lot of bacteria and viruses in this tick, Rocky Mountain spotted fever, Bourbon virus, Heartland virus, but we don't know the transmission rates. So far, people are not getting sick from it. In Europe and in Asia, it can cause alpha-gal syndrome. It can cause problems with low platelet counts, thrombocytopenia syndromes. They've not seen this here in the US, but the problem is going to be as this tick spreads, it's going to be tricky because then we're going to be dealing with a massive tick epidemic. In fact, the Lone Star ticks are overtaking right now the Ixodes ticks, right, which cause Lyme disease. They're spreading actually more rapidly. So it's not now just about Lyme. It's about tularemia, Ehrlichia, alpha-gal, rickets. There's over 600,000 people in the US with alpha-gal syndrome that if they eat meat or, animal products, they could have an anaphylactic reaction. And by the way, Judy, we didn't mention this. I'm the co-host of the Healing from Lyme Disease Summit, which will be airing June 4th to 10th. It's coming up in just a couple of weeks. Myself and my co-host, Dr. Mariah Hinchey, interviewed 50 experts from across the globe on Lyme and chronic disease. We have amazing talks that are about to be live. So if people want to tune into it, my Facebook page, which is Dr. Richard Horowitz, I will be posting the link starting in 11 days, May 21st. I will be posting the link to sign up for this. I would please encourage everyone. It's a free summit. There's no charge. If you want the full, grouping to get everything, there's a minor fee, but you can attend the summit for free and hear all the talks. Wait till you hear the dapsone stories that we recorded, that people will be telling their stories on this summit. It's going to blow people away when they hear the success stories and give the Lyme patients a lot of hope. So for people interested in following me, Dr. Richard Horowitz Facebook. I'm probably going to start a Substack soon, even just to kind of get out a little bit broader talks on chronic disease. But watch out for the Healing from Lyme Disease Summit from Doctors Talks. I think it's going to be an amazing overview of all the updated literature that's out there right now.
I wanted to talk about alpha-gal. So we use a meat diet for an elimination diet to reduce the noise in the immune system, to make sure that certain plant toxins aren't affecting a person. Is it gluten? Is it soy? Is it, this or that? But let's just get down to bare basics. And then alpha-gal shows up. We haven't seen a ton. We've tested a few people through LabCorp Quest. It's been negative, but we are starting to hear more about it. Where is it coming from? I know you sort of mentioned it, but is it something that we should really be looking out for? And then how do you even treat alpha-gal other than not eating certain meats? But is there something that we can do?
So one of the world's experts on alpha-gal, Dr. Scott Cummings, I'm interviewing him for the Healing from Lyme Summit, which is airing June 4th to 10th. In fact, I think he's day 1 or day 2. So here's the story, and I got this directly from Scott. The alpha-gal is primarily at this point coming from the Lone Star tick.
Okay.
So the Lone Star tick, you can identify it because it has a watermelon seed white spot on the back of the tick, right? That's how you can identify the Lone Star tick. The Lone Star tick is dangerous because whereas Ixodes ticks will smell your carbon dioxide and heat signature from 12 to 15 feet away, the Lone Star tick will come running after you from 35 to 50 feet away. Even if you're not in high grass of the woods, it will come running after you. And it will give you, that is the main vector right now for alpha-gal. So we think it's from the saliva, from the bite of the tick that is giving you alpha-gal syndrome. Now, here's the reason you want to keep down your tick bites. And I learned this from Dr. Cummins. I didn't even know this. One bite of alpha-gal, you can be sick for a couple of years, but it can reverse if you no longer get any other Lone Star bites. But the moment you have a second Lone Star bite and it gets in, it's going to be a lifelong condition. There is no way to reverse this if you get several Lone Star bites. So the prevention I recommend for the most part for people is keeping a 20% picaridin spray, Ranger Ready, whatever brand you like, that whenever you go outside, when I do it mostly for mosquitoes because I'm not in high grass, but you put it on your exposed skin and you can use permethrin spray on your clothing to kill the ticks until nucatone and some of these other new things are going to be coming out as tick repellents. But picaridin is a very, very important one with permethrin. Picaridin 20% on the skin. It'll help to repel the ticks and, again, permethrin-treated clothing to kill them. But the problem with alpha-gal specifically is once you get it, the only thing you could do is to minimize it. And I asked Scott this question. Like I said, Scott, this kind of looks like mast cell activation. I said, are you finding like H1H2 blockers, like using Zyrtec cetirizine with famotidine as an H1H2 blocker, and Singulair montelukast, and using quercetin and other antihistamines and things, or Histeo using diamine oxidase to break down histamine, all the tricks we use for mast cell, right? And he said, yes, they can be helpful, but ultimately it's avoidance. So, some people need to carry EpiPens and keep them Medrol dose packs because it can be life-threatening. Most of the cases, it's not. But I'll tell you, one of the presentations that's going to be tricky, alpha-gal presents 4 to 6 hours after you eat meat or anything with animal protein. So if you're having a dinner meal at 6 o'clock, you're not going to get sick until 10 to 12 o'clock at night. You may not put together that it was because of your meal. And some forms of alpha-gal are just gastrointestinal. You can get severe vomiting and diarrhea and think, oh, I got a virus. And it's alpha-gal. So you have to be careful because it can imitate. So and mast cell, by the way, when you have bad mast cell, it can cause GI symptoms, just as gastroparesis can cause it when you get Lyme with autonomic nervous system dysfunction. So you got to watch for these different manifestations of alpha-gal. It's not just wheezing and sneezing and my throat closes up and I'm short of breath. It can also be GI. But boy, you don't want a second Lone Star bite because then you're going to be suffering with this thing. And I do have 1 or 2 patients that have it. And they have to avoid, these specific animal products. But there is no cure at this point. They're looking at a certain drug, monoclonal antibodies. This is kind of a new on the edge that may be useful for treating. This is actually going to be in the Healing from Lyme Summit, my discussion with Dr. Cummins. I didn't know about it. But there is a monoclonal antibody that they're looking at that may be able to be used for people that have a severe case. But apart from treating the way you would with mast cell and blocking histamine receptors and this, there's nearly not much else you can do. You really want to prevent this from happening in the first place.
And is there locations where Lone Star ticks are more common? There is some literature that says that maybe these illnesses can be transmitted to your children or even through sexual contact.
So the Lone Star tick, initially, it comes from the Lone Star tick, Texas, obviously. That's where it got its name. But it's basically from Long Island now on the Northeast corridor all the way up the Northeast to Maine going into Canada. So the Lone Star tick has now taken over that entire corridor of the Northeast, and it's basically spreading that way. So as I said, it's overcoming Ixodes scapularis or Ixodes pacificus from the West Coast. It's overcoming it as one of the more common ticks, apart from Haemophilus longicornis, the Asian bush tick. That's going to overcome everything at some point because it's a hermaphrodite. It doesn't need a blood meal. But as far as transmission, alpha-gal is not specifically transmissible. What you're referring to is Lyme disease can be transmitted from mother to child. So can Babesia, so can Bartonella, so can Rickettsia infections. So you got to be careful. And sexual transmission is a big question mark. We believe that in some cases it can happen. I'm not sure how frequently it happens, but is it possible? It probably is. We definitely need more studies on this. But on the studies that have been done, it's probable. It is a spirochete. But the thing that's different with syphilis and Lyme, syphilis has a spirochetal infection, which is sexually transmitted. There's like gazillions of spirochetes present. With Lyme, that's not the case. There's only not that many spirochetes in your body. They're just causing a tremendous inflammatory response. But I think in the right setting, maybe you've got herpes, right? You've got some open sores. The spirochetes get in. There's probably certain mitigating factors where certain people would be more prone through sexual transmission, but we definitely still need more studies on it.
And then in terms of using so many antibiotics, even if it's for a short period, I always wonder about fungus. I just heard you earlier say that you do use antifungals, but I always have a concern of we see, for example, with SIBO, people use maybe antibiotics, but then it can end up becoming SIFO because they're not focusing on the fungus side. How do you balance to make sure that maybe we're not removing one type of bacteria, but now we're allowing fungus to overgrow?
Yeah, so the way we do it specifically is that in our practice, apart from using nystatin twice a day to keep it down, people are on very low carbohydrate diets. And the beauty of the biofilm agents is the essential oils like cinnamon, clove, oregano oil, and biocidin, they have antifungal effects.
Right.
So we're actually got herbal antifungals with nystatin on board. Rarely I will use fluconazole during treatment, but because it would have to be away from QT prolonging drugs like Zithromax. So usually what we do is at the end of treatment, we usually continue nystatin for a month and clear them out for yeast. And in some cases, I will use a 2-week course or even a 4-week course of fluconazole. And I will tell you that in 1 out of 10 patients, rough estimate, 1 out of 10, where they say, doc, I was getting a little yeast on my tongue despite the best diet. And we would use Mycelex troches. When we clear them out for yeast, they go, doc, all those resistant symptoms of fatigue, headaches, brain fog, they're gone. It was candida. Now, so you're bringing up a good point. You do have to be careful with candida overgrowth. We address it during our protocols, but I would say that sometimes we need to do more aggressive treatments. And of course, if they have mold, they sometimes need other antifungals like itraconazole because the mold spores are in their sinuses, they're in the gut, right? So you sometimes need even stronger antifungals. But I wouldn't say we see a lot of it. But yes, we do see it and we're on it. I mean, and that's the whole point of a very low carb diet with these essential oils and nystatin, but it's something you have to be careful with. But remember, it's a risk benefit trade-off, right? You can't leave these persistent bugs in your body. They're going to destroy your life, right? Nobody would say, oh, don't treat tuberculosis because you're disturbing the microbiome of your gut. And honestly, I will tell you, I've spoken to functional medicine practitioners. Right. I've spoken at IFM and in many of these conferences. They're very hesitant to even use 9 weeks of a dapsone protocol. Why? It's going to affect the microbiome of your gut. It's like, excuse me. If you have tuberculosis, you're going to treat it with antibiotics. You can't leave these infections in the body. You just address the microbiome the way we're doing in the protocols. You've got to be realistic, right? You have to address the most chronic, persistent, right, infections that are going to cause your body havoc. Later, you address the microbiome, but we're addressing it the whole time. We never forget the microbiome. We never forget about fungus and candida. When you read my dapsone articles, especially in microorganisms in September 2023, you'll see we're doing all of this for every side effect of dapsone. And what we're doing, we are addressing it in the protocol, including detoxification, blocking NF-kappa B to lower Herx's using N-acetylcysteine, alpha-lipoic acid, glutathione, stimulating NRF2 pathways with curcumin turmeric, broccoli seed extract, sulforaphane glucosinolate, resveratrol, green tea. We're doing all of this to lower the inflammatory response, to detox people. I'm trying to give people the most comprehensive protocol that causes the least problems. And I'm sure the protocol will still be tweaked over time, but we've been tweaking it for the last 9 years. And I think we've got it pretty well tweaked where it's safe and effective.
A handful of people have said, especially in the mold space, that a lot of the symptoms you mentioned that fall into MSIDS, other than the migratory nerve pain, I'd say that a lot of those symptoms can even fall into mold illness. So if you were to just look into all of the symptom clusters. So how do we know that some of the symptoms, other than maybe doing like the IGeneX testing, how do we know that it's not a mold illness that's actually causing those symptoms versus like a Lyme? And then there are some people then from there that will say, well, if I just eradicate the mold from my system, reduce my inflammation, my immune system can just handle the chronic Lyme. Or so you don't think that's
no way, okay. Never going to happen. Okay. Never going to happen. So first of all, we do a urine test through real-time labs in Texas on literally almost every person in our practice. So we are checking mold toxins from day one. We want to know, have they gotten into you or not, and what role they may be playing. So the thing about it is, the way you differentiated it, Lyme has good and bad days where the symptoms come and go. The joint pain, muscle pain, nerve pain migrates, right? You take antibiotics, you get a hurt, you feel worse. You take antibiotics, you get better. You've lowered the load of the bacteria. Women around the menstrual cycle will say when the estrogen drops, the symptoms come out. It is a very classic clinical picture. That kind of good and bad days where the symptoms come and go and migrate, you don't see that with mold. Now, what you might see is somebody who is not normally in a moldy environment that then goes into a moldy environment, gets worse. Usually those people are very mold sensitive. They'll be searching for apartments or homes because they can't find a safe place to live, right? The husband doesn't smell a thing. The wife goes in there and says, "Oh, honey, I can't live here. I feel sick immediately." They go to the beach for 3 hours and she feels tremendously better. Now, in someone that has Lyme, Babesia, Bart, and mold, but tells me I feel tremendously better out of a moldy environment, I almost feel normal. That means the mold is running head to head or more important than the Lyme and the tick-borne. It doesn't mean they don't have the tick-borne, but it means the mold is playing a massive role in that patient's symptoms. So you learn in internal medicine, and every doctor does, how to take a proper history. When you drill down with the proper questions, you can figure out whether mold is playing a big role or not, based on how sensitive are you when you go into moldy environments, right? I mean, there's a way to check it. And sometimes it's muddled. You can't tell for sure. And then you just got to use binders and stuff. And I've had people, by the way, the reason they did not respond to the dapsone, I've learned this in the last year, was I didn't test them for mold early enough and then tested them. It's not that they weren't getting help from the protocol. They were, but they weren't going into long-term remission. And it was like, what is interfering with them getting better? They were loaded with mold. They detoxed the mold. They went, "Oh my God, doc, that was it." So then when I finally got the mold toxins out, then I saw the full response to dapsone. Their mold is running head and head these days. If you're a Lyme patient, you got to be testing for mold toxins. They're showing up in the vast majority of these people. But it's true, they overlap the symptoms. But as I said, you can differentiate it based on the classical Lyme presentations and what happens with antibiotics.
And then in terms of strengthening the immune system, you don't think that chronic Lyme can be in remission through a healthier, so let's say a lot of the, supporting the microbiome, improving the adrenals, getting them out of mold. Do you think that there's any way then the chronic Lyme can sort of go in remission without any?
In 99.9% of the cases, no. I'm not saying there can't be an exceptional person.
Sure, of course.
And look, we've seen it. A patient comes in, they have a positive Lyme test, they have no symptoms. Mm. Is that because they accidentally took an antibiotic early on for a strep throat or for something else and it lowered the load of the bacteria and their immune system handled it? Probably. But for the most part, you have to really respect the pathogenicity of these bugs. You do not want these bacteria, Lyme disease spirochetes, are being found under Alzheimer's plaques in people's brains. Dr. Dale Bredesen, one of the foremost Alzheimer's experts in the world, I'm interviewing him from the Healing from Lyme Disease Summit. Dale and I are going to have a really interesting 1-hour conversation on the overlaps of the MSIDS model and what he sees in Alzheimer's and what I see in Lyme. And I can tell you this, you don't want to ignore, you do not want these persister bacteria in your body. There's a lot of unknowns. Alzheimer's is obviously not just Lyme, but there are studies showing there's a direct association. I can't say always causality, but there's a direct association with spirochetes, just that there is with pesticides and herpes viruses, and insulin resistance and sleep disorders. There's a lot of things that cause dementia, but you got to put Lyme in there. You do not want these bacteria long-term in your body. So yes, do all of those things. Strengthen your immune system, detox yourself, do all of it. But it's very rare you're going to get rid of these bugs just by doing that. Unless you're and by the way, once you get Bartonella, in the article we published in September 2023 in Microorganisms, we showed the people with BART, they were the people with the worst immune deficiency, with chronic variable immune deficiency. They had the worst POTS. They had the worst neuropathy. They had the worst neuropsychiatric symptoms. So we're not when we're talking about Lyme, most of these people these days have the 3 Bs. They've got Borrelia, Babesia, and Bartonella. So you really got to extend the conversation to the 3 Bs and the 16-point MSIDS model, including mold toxins and everything we've discussed. That's how you're going to get people better.
How much do you think mind-body plays a role? So let's say they've been, to the 40 doctors, spend the hundreds of thousands of dollars and never better. Now they're finally diagnosed with Lyme, but they sort of have PTSD from their illness. They've lost so much of their life through this illness. How much does mind-body work? And, basically the nervous system really being traumatized through everything that they maybe won't heal just even from that because they're seeing the world in a free state.
There's not even a doubt that the mind-body connection is extremely important. I mean, I've even had women clear their trauma and then respond to treatments that they did not respond to in the past, almost as if their immune system was programmed to say, I'm not deserving, there must be something wrong with me from the trauma. It's almost like the immune system gets programmed. So I would say at least 50% of our patients are doing vagal limbic retraining, because they have not just POTS dysautonomia, but they have PTSD from, basically going to so many doctors and being told it's in their head. And, the joke I use with them is, well, your doctor was right. It is in your head. You got Lyme in your brain, you got Babesia, you got Bartonella, you got mold toxins in your brain. But the truth is, people need to do the anti-Hopper dynamic neural retraining, the Gupta amygdala insula retraining. They need to do neurofeedback type trainings. Primal Trust. There's a lot of them out there these days. The Apollo Neurostim. You're going to need to reset your vagus nerve, which is really one of the major factors playing on inflammation. And many of my patients have to retrain their brain from trauma. Absolutely important point. The full healing that you want to get, pretty difficult if you're not going to do it without addressing the underlying emotional components. So yes, very good point.
People with chronic illness that come to see you, do you see many of them get into full remission, be able to live their lives again?
Absolutely. Not even a question that many of my patients are going in full remission. In fact, the ones who see me now actually are the toughest of my practice, because most of the people who get better, they say hello once a year, or they say hello every 6 months. So the people I'm seeing now are pretty much just, either they're new to the practice, right? Or they've got still mold that I'm detoxing, which is why they haven't responded fully to the dapsone protocol, or their POTS is so bad, we're still working on their autonomic dysfunction. There's absolutely not a doubt in my mind that people go into long-term remission and get their lives back. And in fact, when you see the Healing from Lyme Summit, I'm trying to get Brett, who runs it. I interviewed 18 people and their success stories on dapsone. Right now, we've got 5 or 6 that are going to be shown one every day. I'm trying to get them to show all 18. If they don't, I'm going to figure out a way to put it on my Facebook page after the summit for people to see this. But once you see these stories, you'll see this happens to people. We really have hope. We're in a whole new stage. It's just the randomized trial needs to be done to prove to the world what I know. But now that I have 9 dapsone articles published with hundreds of patients in the literature, hopefully I'll get the grant money that I need to be able to do the trial.
Well, thank you so much for your time. I think this is amazing information. I have been really going down the rabbit hole for Lyme, and there's people that recommend antibiotics and herbals and IV therapies, and it's so much information. There's so many bites and so many ticks, as you mentioned, and so many different, you can even get it from mosquitoes, from what I understand. But when I talk to you, it's just like, okay, there's hope. There's hope that there is a protocol. And even in this book that I showed, the How Can I Get Better, you share and you break down like the different, so in this section of MSIDS, or if you have adrenal support, here's some things that you can consider. And I love it. And I think everyone should get this book too. But you bring so much education and evidence-based research into why we should actually consider tick bites, because unfortunately in our carnivore space, there have been stories of people saying, I cured my chronic Lyme with just the diet. And we don't always see that in our practice. And so I thought it was so important that you come on and share.
Yeah, no, I wish, Judy, that it was honestly that simple. I could retire. If that was the case, my wife and I could have a more balanced life at this point in time, and I could retire. But I'm not taking any extended beach vacations anytime soon. I still got a lot of work to do. But no, there's really hope. And thank you, by the way. You're very well educated in this field. You're a great interviewer for this. You really know your stuff. It was a pleasure to have an interview with you today. You're clearly following this very closely. So yeah, excellent. Thank you for doing this today.
And thank you so much. So where can people find you if people wanted to work with you? Where's your practice?
So the website, www.cangetbetter.com, is one way to contact me. There's an appointments line. You'll see there, it's appointments with an S at hvhac.com. It stands for Hudson Valley Healing Arts Center. But basically, for people wanting updates regularly of what I'm doing in medicine, follow me on Facebook, Dr. Richard Horowitz. This Healing from Lyme Summit, I think, is going to be a great addition just coming up in the next few weeks. But mostly watch for, my Facebook page for new additions. And this third science book that I'm really excited to start writing, we just got a great contract. I think it's going to be an exciting book. I don't want to give away too much, but this is going to extend the field of what I'm doing to many chronic diseases, so that all these people suffering with many chronic diseases they'll hopefully have answers, and it won't just be the people suffering from chronic Lyme. So yeah, there's a lot of hope. But medicine takes steps little by little. But I think we're in a really exciting phase right now.
Well, thank you so much again. And yes, please start your Substack, because I do know there are some people that will not use Facebook or Instagram.
I'm going to be
Okay.
starting in the next couple of weeks. Actually, we'll be starting soon.
Okay, that's amazing. Well, thank you so much again for your time. I'll put all of your studies that you mentioned in the show notes, and I'm excited for your summit.
I'll send you the links for all of the articles on dapsone, and I'll get you the links for the summit too.
Perfect. Thank you so much.
Thank you,
I'll
Judy.
talk to you soon. Bye. Thank you. All right, guys, that was an incredible interview. And I try to keep it beginner's Lyme, but then I just was too interested in asking so many questions that it got a little bit more nuanced. I highly recommend listening to this podcast again. And if you are suffering from Lyme, chronic Lyme, or you have been bit by a tick or live in any of these endemic areas, you want to consider the recommendations, the resources that he shared, so that you can talk to your doctor to make sure that you do not get chronic illness. And if you do have chronic illness, just know that there is hope and that you can look into some of the studies that he has shared on how to overcome chronic illness, whether it's chronic Lyme, mold illness, and all the other illnesses that you can be suffering from. The whole point of this conversation was to know that even if your case is so complex, there is hope in healing, and that we should not be letting go or giving up in terms of wanting to get our health back and live our best lives. Okay, guys, make sure to eat a lot of meat, take care of your bodies, protect yourselves from tick bites, because it is the only place you have to live. I will talk to you soon. Bye, guys.